May I then take us on to item 6, into an area of potentially quite considerable risk for us, which is around emergency preparedness, and I'm going to invite Ian Dalton to speak to the paper.
Thank you, Chairman. Patients need the NHS to be available to look after them 24 hours a day and 7 days a week and 365 days a year. It's therefore very important that the NHS has the capability to respond to their needs across those times, and really, regardless of the situation that is faced, is able to meet those needs. We're also absolutely required to ensure that we can deal with potential threats to our own operation. That together is what we would describe as emergency preparedness, resilience and response. You will recall that in April we had a discussion about the need to put new structures into place to improve resilience and response capacity in the NHS and to map onto the new structures. And you will recall that at that time I briefed the board on the important role that the commissioning board has, which is I think describable as a twofold role. The first to ensure that preparedness is good, so that the NHS in England from the 1st of April, when we take on our responsibilities, is able to respond to potentially disruptive threats to its operation. But secondly, to have the capacity to intervene in response to an incident, a crisis, or a severe circumstance, and if necessary, take command of the NHS to ensure that it can share resources to respond properly to the needs of patients. What we have to achieve is that by April 2013, the right people, the right processes and the right systems are in place across the whole of the country. The paper that you've got talks about the processes we are going through to ensure that. Obviously, we start from a good place. The NHS has a good capacity to deal with all sorts of incidents now and is experienced in doing that. Nonetheless, by next April we have to put into place a new set of systems and in particular for this board, a set of systems that we run on behalf of patients in England. We do that by building structures in each area called local health resilience partnerships, which are jointly led, will be jointly led by a local director of the NHS Commissioning Board, this organisation, together with a local director of public health. And we need to ensure that at the local level, at the regional level and nationally, the new systems are in place and ready to go from the 1st of April. So the discussion today, I think, is building on the discussion when we noted the structures in April, and I think quite rightly the board was asking about assurance. How would we know that we're in a good place to go? And so this paper talks about the levels of assurance and the processes that we're proposing to bring into play. Before I talk about that, I should probably just talk briefly about governance, to say that there is a governance structure around this, as members would expect. There's a Department of Health-led process which connects in resilience across the whole of the new system and works across with other bits of government. And then, importantly, I chair an NHS Resilience Steering Group, which brings together our work into the new NHS. The process of assurance that we're proposing will build on steps that have been taken in the NHS in previous areas, particularly preparing things like the Olympics, and has a number of elements. Firstly, we're proposing that there be a tracking matrix that looks at progress at local, regional and national level, looks at the systems, looks at the people, looks at the structures and tracks process on a very regular basis. In addition to that, we're going to have a process of assurance that is based on a set of state of readiness declarations that will be filled in at local level, that will be assured at regional level and collated nationally, and I look forward to discussing those and presenting the results with this board nearer the time. But to support the process, I think we need a couple of other elements as well. Peer review, I think, has a lot of opportunity to help here. Getting one area to look at the progress being made in another area, an opportunity to share learning, I think is a further piece of the assurance process. Again, I think something that was discussed in April and that I very much support, we're organising a series of regionally based exercises across the 4 regions that we have to test the processes, and all of these are scheduled to take place before next April, so that the people who will be doing this will have a chance to actually test out what they're supposed to be doing with the people that they'll be doing it with. So taken together, I think that is the sense of what we're trying to do. In particular, I guess we're working hard to deal with the main risk, which is around time. The 97 days, I think it is very much on my mind here as it is elsewhere. I think we are on track, but I hope that the processes of assurance that I've outlined give the board a sense of confidence that when we reconsider this matter, probably in February time, that the results of this assurance, together with the processes that I've outlined, give us confidence that we'll be in a good place looking ahead to take on our full responsibilities from the 1st of April.
Thank you, Ian. Comments? Maggie?
Yeah. Just switching to Barbara for a second, is this is part of the assessment process of the authorisation, is it, to this element of emergency preparedness?
No, it's not. It's not a particular, specific part of preparedness of CCGs, because this is a system that's overseen by the board, employees, the local area teams, and the local directors. But the authorisation process will look at CCG's basic competence and capability as organisations to respond to a variety of situations, and this would be one of those, and the local area teams will be working with CCGs over the coming months to ensure that there's a fit between the way they work together.
I think that's absolutely right.
And I think there's a clarity of accountability in this that, you know, is there. Item 6 on your report, you know, the role of the NHS Commission Board is to ensure that the NHS in England is properly prepared to be able to deal with potential disruptive threats to its operation and take command of the NHS where necessary during emergency situations. It's you know, there is no one else in the frame in that sense. It's not CCG, it's us, it's this commissioning board, and that's why it's so critical to get this right, because it is a particular responsibility of it.
Yes, it is a responsibility, and I think I'll just make 2 observations. One, because it's that responsibility, we've built our structures to take account of that. Yeah. So we've got senior people at local area level working with CCGs and hospitals at the local area and with local directorates of public health. We've got strong arrangements being built at regional level, and we've got a strong national support centre role here. So I think the roles that we've built support that. I think the other thing that would be wrong to miss the opportunity of is that, you know, having a single national organisation undertaking these roles, I think gives us an opportunity to learn from best practice and ensure that we ensure that that's a universal set of expectations. So as part of this exercise, there's a big piece of work going into redefining standards, producing new documentation, new systems, which will then become the expected approach across the whole of the country. And so at the end of this, I think my strong intent is that we leave ourselves in a very strong position across the whole of the country, and certainly that we're ready to go from the 1st of April.
And how do we deal with the financial consequences of emergency? Is that something that there's some allowance for, or it's dealt with at the time?
I think the simple answer is it's dealt with at the time, because by definition you can't predict what it is, and therefore you have to respond to it. And frankly,
So
in the worst
no
types of
allowance.
Emergencies,
No.
finance has to take a bit of a back seat for a while you deal with the emergency, and we sweep it up, as it were, afterwards. I don't think there's any systematic way in which you can prepare yourself for all of that.
Would you like to say a bit more about the transition risk, which is this bridge as the present structures are dissolved and the new structures come in? To what extent are we not just changing structures but also losing memory? And how are we managing that risk and mitigating against it?
So that's an important question. Let me just try and pick it apart very briefly. First, we should be clear that the statutory accountability for ensuring a safe system, there's an unbroken chain. The current organisations, the strategic health authorities and the primary care trusts with their personnel are responsible up to midnight on the 31st of March. we take over formal responsibility 1 minute after that, and our systems and people come into place. But this sits in a wider context of transition, as your question rightly identifies. So in a way, what we've done is very much mirrored the arrangements that have happened within the NHS since the 1st of October. So as, to give an example, local area team directors of the Commissioning Board and regional directors of the Commissioning Board have been appointed within my Operations Directorate. They've taken over functions on behalf of the current statutory organisations and built their teams to provide that capacity. So effectively, instead of a baton passing exercise where, you know, on the midnight and 1 minute the baton passes, what we're doing is building transition by putting new people into place so that the current organisations don't suffer a sort of an attrition of capacity and therefore get left in a vulnerable position. The other thing we've done is to try and fast track appointments into some of these posts within our own structures. So at the national support level and at the regional level, we've moved ahead to ensure the early recruitment of people who have particular skills in this area and can help us build the new system. So I think we tried to take a comprehensive approach to ensuring that there's a managed transition here that ensures that the system is safe right through the transition and into the new arrangements.
And Malcolm, could I just pick up on the directors of public health will be included in that, so they're in transition to local government, but they will be included in the current training and development.
So the role of the Director of Public Health is very important in this. The model, I think, rightly identifies the Commissioning Board as, you know, this is one of the rare examples where we are effectively the NHS in response to a crisis and in a different role with the NHS than we normally have. But nonetheless, we can't do that without the active support of local government. Local government in its public health functions plays a critical role, obviously in relation to incidents when they happen, but also, absolutely importantly, in the preparation for those incidents in times when there isn't an incident. And so bringing people together, helping them work together, get to know each other, train together, work to common approaches when there isn't an incident, puts us in the strongest position to deal with an incident if and when it occurs.
Thank you, Ian, very much. We are asked as a board to note the progress to date, the prospects, and endorse the approach. I take it that we're content to do that.
Thank you.
Thank you very much. We turn now to item 7, which is the board's role in maintaining quality. And I'm going to invite our Chief Medical Director, Sir Bruce Keir. Bruce.
Thank you, Chairman. Since 1948, our citizens have rightfully, I think, been proud of the principles on what NHS is based. But sadly, occasional pockets of poor quality care have surfaced, which have dented public and political confidence and professional esteem. So Aradazi's review in 2008, I think, rightfully and justifiably focused on quality. And the end result of that is that we have a definition of quality which we all understand and which is now enshrined in the Health and Social Care Act. But part of that was a recognition that quality is everybody's business. It starts with individuals, it becomes aggregated to organizations, and is the responsibility of those boards as well. And as a further recognition of that, the review recommended the establishment of a National Quality Board, which has been up and running since 2008. And that consists of the chairs of NICE, the Care Quality Commission, Monitor, and more recently the chief executives of the GMC, the National Trust Development Agency, and Health Education England, supported by appointed lay and clinical experts on quality. And the National Quality Board recently considered how quality might be maintained and indeed improved in the new system. And they issued a report to that effect. And that report committed each constituent organisation who was a member of the National Quality Board to have a board-level discussion on their respective roles in maintaining and improving quality in the emerging system. And this paper, therefore, seeks to describe and clarify the Commissioning Board's responsibilities around maintaining quality, and that is what we're doing today in public. So the challenge, I think, in the new architecture is to work out how together we all maintain the essential standards of quality on the one hand and continuously improve quality and outcomes on the other. I think it would be fair to say that the prime focus of this paper is on the former of those two. So the board is asked to support the description outlined in the paper of the commissioning board's role and advise whether the actions outlined are appropriate or indeed sufficient. So the paper poses, on the basis of the National Quality Board deliberations, a series of questions. The first of which is, who sets the quality bar? And it seems to me that there are two elements to the quality bar. The first is the essential standards are set by the CQC's system of registration, and that is done with a set of nationally applied standards. And our role is to work with the CQC to ensure not only that our objectives are aligned with theirs in terms of quality, but to raise the quality bar when we deem that to be appropriate in issues such as MRSA or venous thromboembolism prevention. The second way that the quality bar is set is at a more local level and is determined by the contractual requirements and aspirations of commissioners in conjunction with their providers. And our role, I think, is to support CCGs with data to inform their decisions and to help them through the planning guidance. But most importantly, I think, to give them the freedom to determine their own requirements within a coherent and consistent framework so that they can drive up quality in the areas that they deem most deserving in their particular locality. The second question outlined in the paper is who is responsible for maintaining quality. Ultimately, I think the leadership in provider organizations are responsible for ensuring that their services meet the essential standards laid down by the CQC. But commissioners also have a responsibility for quality. And they have responsibility for quality because they are procuring services on behalf of often worried, sick, and vulnerable people who entrust their well-being to the service that different organizations have oversight of. So the commissioners have a very significant responsibility to procure the best possible services on behalf of those patients. And it seems to me that this is a pretty major shift in emphasis for many commissioners, both at a procedural and a philosophical level. So our challenge, I think, is to support them to understand this and to be equipped to fulfill their role. So support in this area has been prioritized for development by April as one of the work streams associated with the Commissioning Assembly, which we will be having next week. The next major question is, how do we spot early signs of failure in our NHS? It's clear that commissioners, regulators, and other organizations must work together to share the information that they have, because so often when we've seen failure, one part of the system has either recognized impending failure or recognized actual failure, but has not been as quick as they might have been in sharing that information. So against that background, the National Quality Board has proposed a network of quality surveillance groups to provide a forum for sharing exactly that sort of information. The quality surveillance groups will be constituted of clinical commissioning groups, providers, regulators, local authorities, local education and training boards, to name the main players. But the commissioning board will play a significant role in the sense that it will support and facilitate the quality surveillance group networks across the country. And these are currently being piloted in the Midlands and East through a program led by Paul Watson and a steering group of organisations from across the system in that locality. We hope to be issuing guidance for the quality surveillance groups in January to support their rollout next year. One of the other things that we need to do is we need to ensure that the commissioning board staff who are associated with facilitating and administering the quality surveillance groups understand the collaborative nature of this endeavour. The next big question I think that we need to address is, how do we respond to potential or actual failure? And the National Quality Board ventured into that territory in 2010 when it raised the concept of risk summits. Now, in the new system, risk summits will continue. Risk summits and quality surveillance groups are not statutory responsibilities, but rather their purpose is to help organisations discharge their responsibilities in the knowledge of each other's information and intentions. So the Commissioning Board may be called on from time to time to support and facilitate or even chair a risk summit. Local area and regional teams will need to be equipped to do so, and we will be producing updated guidance on how to run a risk summit to reflect the new system. The next question is, who is responsible for driving continuous quality improvement? And it seems to me that improving quality and outcomes is a very significant, if not primary, purpose of the Commissioning Board, because quality becomes the first victim of organisational or professional complacency or stasis. So we need to keep the momentum going. And I think the Commissioning Board has 3 roles in respect of improving quality. The first is, quite simply, as a leader of the overall commissioning system. The second is as a direct commissioner. It's a firm belief of mine that anybody who undertakes any form of clinical endeavour has a duty, a moral and professional duty, to be able to describe what they do and define how well they do it. And it's an aspiration to achieve that across the system, which I think we can start to drive as a direct commissioner by standardising an objective process for commissioning those services which we commission directly, and to ensure that, where possible, that commissioning is based on a process which is around either best practice or, preferably, where the information is available, on outcomes achieved through the service that we're commissioning. And that has to be our ultimate goal. And then thirdly, we have a role as a system leader for quality, simply by virtue of the fact that we are responsible for delivering the outcomes that are articulated in the outcomes framework. So at the moment, we have strategic approaches for delivering each domain in the outcomes framework, and those are in development, and the board may be interested in discussing those on a later date. But we will be discussing them in any event at the Commissioning Assembly on the 14th of November. So thank you very much.
Thank you very much. Colleagues? Can I ask you, I mean, there are many aspects, of course, to quality and to safety, and they intersect, and there are institutional aspects, there's the environment in which people work, there's the culture and the behaviour, but there's also the individual. Just help us to understand how this approach would help to safeguard against, for example, a surgeon of whom it was alleged that unnecessary or incompetent procedures had been conducted. How would this new approach help us to ensure that such conduct didn't occur, and how would it help us to detect it if it did occur?
There's another part of this which isn't reflected in the paper, which is certainly revalidation of members of the medical profession. But before I come to that, it seems to me that the real essence of quality is driven in that very private and privileged environment where one person seeking help from our healthcare system engages with someone who is offering it, whether that be a doctor, a nurse, a physiotherapist, whoever. And the conduct of that encounter within the 3 defined domains of quality, about whether it's an effective encounter, whether it's conducted in a safe way and in a safe environment, and whether it leads to a as decent an experience as possible for the patient, is the very essence of quality of care. So everything that we do whether it's around the appointments process for individuals in the system, whether it's around informatics, whether it's around the real estate or the environment, is all about ensuring that that person who is seeking help gets the best possible help they can. So the whole of our healthcare system is simply an aggregate of multiples of that single encounter. So in terms of, you referred to a surgeon or a doctor and their conduct, what revalidation of doctors does, it brings into the system a standardized approach to appraisal of individuals, which in turn is aggregated up through the organization through which they work, to the local area teams, the regional teams, and ultimately to the commissioning board. One of the things that I think is important and which has gone unrecognized for some time is the value of appraisal to an organization. So in so many organizations it is seen as an add-on or as a bit of a distraction, when in fact appraisal is the one time that an organization sits down and talks to an individual about what they can do to help each other deliver a high quality service. And I think it's going to be the standardization and rollout of effective appraisal that is going to be the guardian against the issues that you raised, Chair.
Yes, no, I totally take that. I suppose the one thing that still would concern us in the test of the system is the clinician who is able to please their patients and please their colleagues, but still be doing something that lacks the quality or the safety.
Well, I think that comes back to a statement which I made and may have been hidden in the overall presentation, which is that I think that every professional has a duty to be able to describe what they do and define how well they do it. And that means you need to understand your outcomes. I believe you've got a professional, social and moral responsibility to be able to do that. I think that part of the appraisal process should put in place measurement systems which enable an organization to identify whether somebody is meeting not only their aspirations but the aspirations of the organization for which they work.
Thank you. Have more.
Very supportive, particularly those last comments really, but and this is a more mundane point in a way, but local government is in figure 2 in the local area surveillance, but there isn't, when it goes to regional level, there's no local government. And I know Bill's had discussions with local government about this, and they're generally content with the way. But how will that? Is there a gap there?
I'll defer to Bruce, but I think it's a very good question, and certainly my understanding in working with Bruce and his team is that we're very open. I mean, of course, the local government doesn't always organise itself on a regional basis, which is why there wouldn't be an automatic kind of hand across. But I think we'd be very open, drawing from the local groups to have some local authority representation as well.
Yes, we can ensure that happens.
Yes.
Can I just make a point about the revalidation and our responsibility in relation to that? It's just worth kind of mentioning all of this, because each doctor in each organisation, provider organisation, the medical director of that organisation is what they call the responsible officer.
Yes.
Who's responsible for making sure all of that happens. Above that is the responsible officer that makes sure all the hospitals do it, and that's the medical director of the local area team. So we have there's a direct connection with what we do, and then that goes to all those go to the regional medical director, and then all of them in the NHS go to Bruce. So there's a direct chain in, and let me change command, I mean a kind of golden chain or whatever it is that goes through that. So this is really critical importance to us, and a really important kind of bit of our responsibility in terms of leveraging the system, but also, I think when we were talking earlier about the potential for clinical risk, it's a big issue for us. I think we really do need as a board to sit down and think about how we're going to deal with that.
I think the reach is even further than that, David, because the responsible officers also reach into the private sector, the pharmaceutical sector, industry, and defence.
Clinical risk is something we're anxious to come back to on future occasions. Margaret?
To a large extent, Chairman, that answers my question, because really I think that it was triggered by the discussion that you had about appraisals and where do they land and whose responsibility is it to oversee the whole structure. And really I think what's going to be critical about ensuring that there is proper assurance embedded within the system is to have clear lines of sight, and that's what I really am very keen to see established.
Yeah, and then
Yes, so just the other side of it, I think there's two. So there is obviously that, important revalidation role that David talked about. I think the other thing that, in some ways, parallels the conversation, albeit in a very different context than we've had with the emergency preparedness debate, is that this is another set of organisational arrangements that we need to have confidence in at national, regional, and local level. So, in a way, if you think about the quality surveillance groups, our expectation is that they're in place universally, that they work to common standards, that they bring the right people together, and that they do the business in a consistent and credible way, and that they interface with other bits of the system so that there's a national overview as well as a local response. And so I think it's a big organisational change and challenge, this, which I think if we get it right, and I'm sure we will, potentially offers real opportunity for national consistency. So in a way, aside from that sort of personal line of sight, there's an organisational line of sight here, and we need to get both right, I think, to do well by patients.
Bill?
Thanks, Jim. I just wanted to emphasise within this, I think, the importance of patient and carer voice, and the whole system being very open to reaching out, really hearing, really listening, really understanding. I think it's important in the early signs of failure, and it's reflected with the presence of Health Watch on the local groups, but it is probably broader than that, and I certainly think this system will have to make very positive steps to be able to hear and listen to certainly some of the most vulnerable groups who perhaps won't automatically be offering opinion in the way that others might. So I think that patient and carer voice being really present in the system, I think is quite important.
Well, thank you very much. Thank you very much, Bruce, for the paper. We're asked as a board to note the board's role in maintaining quality and to endorse the action that the various directorates of the board are taking to ensure that we fill our distinct role and work with other parts of the system. I take it we are content to agree. Thank you very much.